this venom, and then the venom will be separated using HPLC. And from the peaks of the HPLC, an SDS page electrophoresis is performed to separate further the venom's peaks using their mass, based on their mass. And then the bands are selected and they are digested using a digester. This is performed using trypsin, which is an enzyme that will cut in specific amino acids and generate peptides that are easier to obtain the sequence. Okay, and afterwards, the peptides are analyzed with mass spectrometers, and the sequence of these peptides are obtained, and with just a sequence, maybe 10, 12, 15 amino acids, you can know what is the protein family that belongs to this protein. Also, if it is available, the N-terminal sequence is performed to some of the peaks from the HPLC, and this can directly also identify the protein. And using all these sequences, you can therefore determine what is the composition of the venom. The abundance is determined using the area under the peak with the HPLC, so that allows to estimate the quantities of each of the families of the venoms. So first, regarding the pit viper venomics, pit vipers are the most important medically in our country. So the first work was performed by Dr. Yamilet Angulo, the director of the institute. She went there to Valencia, and she studied, at that time it was called Anthropoides mexicanus and Anthropoides picador. And one of the very interesting things that was obtained from this work was that the proteomic composition was able to predict the toxicological profiles. So, for example, we can see that Anthropoides picador is a very hemorrhagic venom, and this is due to the fact that it contains a lot of snake venom metalloproteinases, as you can see. While, on the other hand, Metromycoatrus mexicanus, in that time, Anthropoides mexicanus, contains more phospholipases, and therefore it has more myonecrotic activity. Another quite striking finding from these studies was when the rattlesnake Crotalus was analyzed. So the neonates from Crotalus, we can see here, contain protoxin, which is a neurotoxic component in the venom, and this protoxin disappears in the adults. So at that time, the antivenom was not able to neutralize this protoxin, and therefore it was important. This finding was very important because in case of a bite caused by a neonate, the antivenom would not be able to neutralize the protoxin. And so we can see how in some species the ontogenetic changes are quite important, significant, in the sense that, for example, the toxin almost completely disappears, and the metalloproteinases, as you can see here, just 2%, and then they switch very significant, and it composed most of the adults. Then we have the geographic variability that was obtained from the study of Botrops aster, which is the most important species here in our country. Causes most of the bites, most of the deaths. And as you can see, the Caribbean venom is a little bit different from the Pacific venom. We can see, for example, with the serine proteinase percentages, in the Caribbean, you can see more serine proteinases than in the Pacific. And also there are some slight variations more phospholipid bases in the Pacific venom, a little bit more snake venom metalloproteinases in the Pacific venom also. Then the arboreal snakes from our country, venomous snakes from the genus Botrytis. These snakes all have arboreal habits, same reported diet, but they have striking differences in composition. So, for example, the Botrytis lateralis snake is dominated by snake venom metalloproteinases, which is a hemorrhagic venom, while, for example, the Irish pit viper, Schlegel, contains mostly phospholipid bases. So it is a venom that will be more myelonephrotic. Then, for example, Botrytis supraciliaris is dominated by vasoactive peptides, for example. And then the case of Botrytis nigroviridis, which in the center of the country, this snake actually, the venom from this snake does not contain any metalloproteinases, which was a very striking finding, and was dominated by an unusual phospholipid basis, phospholipid base A2, which is a protoxic, like neurotoxic phospholipid base. So that's also quite a striking variation between all these species. This year, we reported the final venom that still had to be analyzed from Botrytis nuvestris, which is also an arboreal snake, quite similar to Botrytis nigroviridis. And as you can see, it is also dominated by snake venom metalloproteinases, which is also very striking, since the most similar snake, Botrytis nigroviridis, for example, in the central part of the country, does not even contain metalloproteinases. So it's quite striking findings. Okay, then the case of the Portidium group and Cerophilium, when these snakes were analyzed, there was a time in which they belonged to the same group, but after analysis from the venoms, it was this helped or was part of the characteristics that helped to differentiate Cerophilium, at that time Cerophilium quadmanis, from the Portidium species, had a little bit different venom from Cerophilium, and Cerophilium was called Cerophilium sasai. Actually, two magnusas presented previously. Then, from this strategy, it is possible to discover novel toxins. So we have this castle type inhibitor light, which was never reported in snake venoms previously at that time. And thanks to the proteomic studies that were first performed in the laboratory of Calvete, it was reported that 8% of the venoms from Schlegel, was composed of this castle type inhibitor. And then we isolated the protein. It's not really a very toxic protein, but still it has quite a significant presence. It's able to inhibit trypsin at an acidic pH, and it causes it. Also, this other toxin, nigroviridin toxin, was quite interesting because it was the first time that a toxin similar to acrotoxin was found in a non-rattlesnake species of the New World. Neurotoxic toxin was found in this species. Okay, and now for the other part of the presentation, we have the coral snake venomics. So coral snakes are also species that are found in our country, and they have also composition of venom, which is quite characteristic, since these venoms are mainly composed by either three-finger toxins or phospholipid bases A2. So the first species that was studied here was Micrus nigrosinctus, which is a venom dominated by phospholipases. And then other venoms were also studied. And as you can see, the venoms either have the three-finger toxins. You have the case of multifasciatus, which has a lot of three-finger toxins, which are neurotoxic. Or, for example, they are dominated by phospholipases, like in the cases of nigrosinus, Icrurus claris. Last year, we also analyzed one of the coral snakes that was still missing. It was Icrurus jatesi, and it was placed with the phospholipase predominant venoms. So, as you can see, this is not only for our country, but in the whole of America, the Icrurus species with the coral snakes, they are either dominated by these phospholipases A2 or the three-finger toxins, which are both neurotoxic by different mechanisms, but they have the same effect. We were also able, through our collaboration, to perform top-down proteomics of coral snake venoms. The advantage of doing this top-down proteomics is that the whole protein is analyzed when you use this strategy, and therefore you can know what is the exact mass of this protein. And well, the most important finding from this study is that there are some shared proteins in different species in the sense that the same protein with the same sequence is found sometimes in 3-4 species of these Icrurus snakes, which is quite interesting that these proteins are shared among a lot of different venoms. Right? And also the trend in which the venoms are either dominated by three-finger toxins or phospholipases A2 was also confirmed using this strategy of top-down proteomics. We didn't find a protein that was shared by all the species analyzed, but by 2 species, we found some of these proteins. Okay, and we have that also in the coral snake venoms. There is when we study the composition, it affects also the efficacy of the antivenoms. So, for example, in the case of Costa Rica, the antivenoms, when they are tested against phospholipase A2 predominant venoms, they are able to neutralize very well the effects. While with the three-finger toxic dominant venoms, the antivenom is not so able to neutralize the effects. This is mainly because the antivenom has been classically prepared using the Icrurus nigrosinus venom, which is the most abundant coral snake, and which is a phospholipase A2 predominant venom. And so, finally, conclude. So these studies of venom composition, they are allowed to study the biology, natural history, taxonomy, and evolution of venoms, snakes, and also to discover novel snake toxins, to study the pathophysiology of venoms, and also it has implications in serotherapy and the effectiveness of antivenoms. So, thank you very much.
Thank you very much, Miguel. And we have still time for questions regarding proteomic studies. Yes.
Thank you very much. Could you imagine that for a given patient, you use the proteomic to identify the responsible snake of the life?
In the future, maybe. Right now, it is quite difficult from the blood to obtain the venom, to identify the venom components, but we have, together with Marianka, she performed some experiments in injecting venom in rabbits, but only after affinity chromatography we were able to identify the presence or absence of this venom toxin. So directly from the blood, it's still difficult.
Okay. From two different strains, okay, the same components but have different properties. Are we sure that the components are the same basis from bottles and basis from products? Are we sure that they are really the same?
No, just from the same family, but to know if they're exactly the same, you need to sequence the whole of the, to obtain the whole protein sequence of the phospholators, which is possible, but when you make these proteomic studies, generally it's just to have like a general overview of the venom. But if you want to go deeper, then if you obtain, for example, the transcriptomic data, and then you apply the proteomics using the transcriptomic data, and you obtain the sequence, then you can for sure know if they are the same or not. But you will need that information.
You mentioned some difference in the composition, juvenile versus adult, and so that make a difference when we are treating the patient right, because the antivenom may be not as efficient as it should be. Do we have an idea of how much people are concerned with this problem? You give the right antivenom, but it's not efficacy just because the snake was juvenile.
Yes. Well, as far as I know, the accidents by humans are not that common as the ones with adults. And also they inject less amount of venom. So, yeah, the scenario could occur that it is a juvenile and the antivenom is applied to occur. But probably it occurs less.
If I may, yes, in the case of both aspects, many mice by juvenile species, even though the proteins are different, they can work very well against both adult and juvenile, so there is no problem. In the case of the rattlesnake, as Julian explained, that's a different story because the antivenom doesn't work with the juvenile member. However, from the information we have gathered in hospitals where rattlesnakes are, and even cases treated by juvenile specimens, the evolution, clinical evolution has not been bad. So that may be because what Jan says, the amount of venom is low. But unfortunately, in the case of both those aspects, even though there are differences, the antivenom works fine against juveniles.
Yes, that change is just because in the rattlesnake is really like a striking difference between juveniles and adults, but it's not that in all the species.
In the case, thank you, Julian, for your nice presentation. Time. So, great. So now, we start to understand to be the top, we talk about the top, proteomics. I just know that word. Right. In the case of ideas, how can you describe using the proteomics, your work, proteomics profile, in the case of two snakes and two different countries? And I know you have been working both of ideas and several others. I don't see so much difference. Can you explain to us? Because we have some what in your work, how can we apply that proteomics profile in the case of both the states? Maybe Shema can help you.
Yes. Yeah, for the moment, the information is mostly of protein families. But the issue here is that sometimes you can have a phospholipase, and they are from the same protein family, but proteins are quite different, the sequence and everything. So, if it is possible, for example, to obtain transcriptomic data, and then also use the proteomics to confirm the sequence of each toxin or most of the toxins, then it is a strategy that will help to know in more detail the differences in the proteins. So,
Thanks for the presentation. My question: have you studied the performance of states that were born in laboratories compared with those captured from the wild? Difference and how could apply the
yeah, it's an interesting question. Well, I have not performed those studies. I don't know, Bruno, if he has performed or knows. Still
But it's whether we have tested if there are differences between venoms. Okay. Because there are two studies, right? Very good. Exploration is not so easy to talk about this. We need a very good end. So there's not to distinguish between this one. Maybe even argue that the variable that we want to start with activity. So there are some studies. For example, recently, some paper with the very age things, the old things in the certain, they have some changes in the venom, and they were proposing that we will have to, I will say, to retire things. So it's more. Yes.
Thank you for your presentation. I want to ask you how you manage the study of
the study.
same protein.
Yes, well, in these studies, which are to get a general overview, we just generally report the protein families. Also, we measure the total mass of intact proteins in some of the most relevant peaks. So sometimes you can also know in one peak that the mass, the total mass is 30,000 something, right? And then you compare with other similar peaks and you see the difference. So yeah, it is possible if you want to go deeper to know the exact mass, to get the whole sequence. But generally, the idea is just to get the overview. But it is possible to study these isotopes, to get the total mass, to get the whole sequence, if you want to do that. But it's also a lot of work, right? If you want to do that for all of the proteins in the venom, it's really, really a lot of work. But if you want to focus on one important, it is possible.
Yes.
Are you currently using this proteomic guidance to improve the venom production?
Yes, actually, a lot of the results from here, then they were obtained some years ago, and they have now changed the immunization mixtures to produce the antivenoms. So, and now they are able to neutralize some of the venoms that were not previously neutralized when the studies were performed.
Thank you very much for that. And our next speaker is Professor Bruno Magabat from the Department of Medical and Toxicological Critical Care in Paris Cité University in CERN, in Paris, France, and will provide the second version adjuvant pharmacotherapy in snake envenomated patients. Welcome, Bruno. Thank you.
I'm sorry. So you have the point. So, good morning, everybody, and thanks for the organizers, Professor Guterres, Professor Gabor, Rizier, for inviting me to come here. So, as you may know, I'm not a specialist in toxicology, and I take care maybe of one or two snake envenomated patients per year. So it's really a short experience because there is no snake in Paris except two kinds of Vipera in a small forest. It's quite very rare cases, but it's always a pleasure to come. So I will consider things from like a theoretical point of view because experience is limited. And as I was presented, so I'm a clinical toxicologist and intensivist in Paris. So I have no conflict of interest to declare with this presentation. So first of all, of course, all of you know that envenomation is a very serious and complex problem because venoms are rich in various toxins, and additionally toxins are different from one species to another, from one region to another, from one age to another in the same species. So this is one very complicated aspect, much more than I have to manage in drug poison patients. Of course, these venoms will be responsible for various organ injuries. You know, of course, hemostatic alterations due mainly to consumption, coagulopathy, and platelet disturbances, myotoxicity, neuromuscular paralysis, hemorrhage, cardiovascular. So this is like a very polymorphic consequences at the organ level. This requires, of course, various pharmacotherapies. Also, snakebite envenoming requires emergent treatment. The only recommended treatment by WHO is serotherapy. Also, this treatment has many issues, including low access in some areas, especially rural population, low effectiveness in neutralizing local effects, and of course, high costs. So even if it is available, sometimes patients will be referred with delay. And as shown on this slide, the antivenom therapy will act very mildly on the local effects and sometimes not enough on the systemic effects of the venom. And therefore, we will have some complications due to the local effects and, of course, some general complications that may lead to mortality. So it's important to consider some adjuvant pharmacological therapies to anti-serum venom treatment. Of course, when the patient will be referred to the hospital, you will consider some risk factors of severity, and you will discuss the usefulness or not of antivenom. So we will not go there. And for each snake, have different scales and different risk factors.
And this should be prioritized as soon as the patient has been found or has been admitted to the emergency department. The patient should be immediately transported to a facility able to administer the antivenom and, of course, the supportive care. And, of course, even at that level, when you will have to remove what is around the bitten part of the patient, to reassure the victim, to immobilize, to monitor airway and breathing, you will have to consider some therapies like analgesics, and you know that probably in the future there are now some experimental studies to support the usefulness of some drugs like ointment containing a nitric oxide donor that may impede the intrinsic lymphatic pump and prolong the lymph transit time of the venom before entering the bloodstream, and thus give more time to consider antivenom. And in the future, of course, different additional small molecules will be added to the antibodies, and these are synthetic inhibitors that may have some interest. And Professor Gutierrez have talked about one of them, varenicline, which has been demonstrated as possibly interesting based on the recent published RCT. But this is the theory. So now let's move to the practical aspects and consider what are the real issues. So what is real life treatment of snake-bitten patients? So if we go to Uganda, for instance, we see that only 6% of the patients will receive antivenom. So all the others will receive only adjuvant treatments, no antivenom. And this will result in a limited morbidity, 0.2%, mortality 0.2%. Of course, in other areas like French Guinea, which is richer, we see that here more than 60% will receive antivenom. And this will improve significantly the outcome of the patients with the decrease of the requirement of mechanical ventilation, ICU, the shortening in hospital stay, and probably trends to improving survival. So, of course, the antivenom remains the mainstay of the management, but additional therapies are important. So I will discuss 5 aspects of pharmacotherapies. And of course, this will open some discussion. So first of all, of course, since the most important treatment is antivenom, so could we administer some additional therapy to reduce or prevent the adverse reactions to this antivenom? There is one important RCT, and this has tested different drugs and combinations. You see here epinephrine by subcutaneous route, promethazine by IV route, hydrocortisone by IV route, and all their combinations. What is the result of this study? Only epinephrine is effective to reduce side effects. So all the other therapies are unuseful. And this is, of course, important, especially in the countries with high incidence of adverse effects, although the need to improve the quality of antivenom cannot be overemphasized. There is a systematic review and a meta-analysis of spray medication drugs. And we see here that overall, there is a substantial benefit from pre-medication with epinephrine. There is a marginal benefit with the combination of other medication. There is no benefit of hydrocortisone or corticosteroids regarding the timing, the rates, and severity of adverse reactions. And of course, this is preliminary. Probably we can consider some modifications, and because we don't know exactly the synergism between these drugs. but corticosteroids seems to have just one interest, one application is the treatment of serum sickness. So days after the envenomation, the anti-serum and anti-venom administration, and in these cases, corticosteroids are effective. But there seems to have no other indication, especially to reduce anything, even in tolerance, to improve the tolerance of antibiotics. So the second aspect is analgesics, because of course it's important. Probably pain appears immediately when the patient is envenomated, and acetaminophen, the usual opioids, but also ketamine appear to be effective, relatively safe, and even cheap in resource-limited settings. Because this is important, as the venom will activate different pathways of pain, including the production of neurogenic inflammatory mediators. It is important also to consider the local aspects. So there are different therapies that have been studied to limit the extension of the inflammation. And you see only low-intensity lasers, pulsed ultrasound therapy have been shown to have some effect to limit inflammation or to accelerate the recovery of the muscle damage. Of course, the use of tourniquets, corticosteroids, antihistamines, cryotherapy, plants, oils remain question. There is no study for that to see their effect on the local side. But despite all these treatments, local complications may progress to more serious conditions. And here also, fasciotomy should be considered with very careful. So this is a study, a retrospective study done with rattlesnake envenomation in the US. They observed that venom-induced compartment syndrome remains rare, but fasciotomy continues to take place without compartment pressure measurements and without repeated antivenom dosing. So they analyzed the situation and they concluded that in the absence of clear objective, mainly when you have a limb-threatening compartment syndrome due to edema, fasciotomy does not favorably impact morbidity and is associated with increased hospital stay and increased cost for the management of the patient. So this should be only considered in an extreme situation. Third aspect is infection. So I know that Adam will present on that, but rapidly see there are differences between our two approaches. So here also a study with the US about infections following rattlesnake envenomation. Confirmed infections seems rare, 0.97% of the bites. So for these authors, the systematic antibiotic prescription is not justified. Additionally, there are a variety of pathogens encountered that preclude the use of any single effective antibiotic. So they recommend to use systematic preventive antibiotic. And this has been concerned also in different other experience. Here is the experience from French Guiana. Wound infection is frequent in the most severe cases, grade 2 and grade 3 envenomation, especially in the presence of necrosis, thrombocytopenia, rhabdomyolysis. And here also, there are not usual bacteria that are mainly involved in the infections. This is also the same in China with other snakes. and you see that the most frequent patients here are Morganella morgani, Staphylococcus aureus, but the majority of the isolates are resistant to the first-line antibiotics recommended in the literature. And these authors recommended fluoroquinolone. This is also encountered in India with more resistant strains to antibiotics. You see that in this study, even though the most important bacteria are Staphylococcus aureus, Klebsiella, Pseudomonas aeruginosa, the most effective antibiotics are large broad spectrum antibiotics, meropenem, colistin, clindamycin, linezolid. So the usual antibiotics are not efficient. So all these lead to these kind of recommendations, even though they are based only on retrospective analysis. First, prophylactic use of antibiotics should be discouraged. Antibiotics should be only reserved for patients with demonstrated or at high-risk infection. And that means that if they have already severe local envenoming, local signs of infection, or incorrect methylation of their wounds. Antibiotics should better be based on the susceptibility of bacteria, usually isolated from the affected tissues and from the snake's oral cavities. And the usual isolated microorganisms are mostly Morganella morgani and Pseudomonas for all species, some gram-positive like Staphylococcus aureus and Staphylococcus fetalis, Ammonia hydrophila, and so on. So, based on these species and their susceptibility to antibiotics, probably the combination of piperacillin, tazobactam, ciprofloxacin, or a third generation cephalosporin are the most appropriate and should be given as empiric therapy. Of course, if it is possible to identify the causal bacteria later on and to adapt the antibiotics by changing to narrow spectrum drugs based on the results. The fourth subject of pharmacotherapy is drugs that could interfere or improve the alterations in coagulation induced by the venom. So heparin has been discussed, either non-fraction heparin or low molecular weight heparin. And you see, based on this meta-analysis of RCTs, there is no benefit to use heparin to improve anything in the consumption coagulant. Even in France, it is even worse if you give heparin, even preventive low molecular weight heparin to the patients, you will have deleterious effects regarding hematomas, functional discomfort, length of hospital stay will be prolonged. So this study from David Boyce in France, of course, support the effectiveness of the antidote, which is already known, but the use of heparin is not recommended. What about clotting factors? Can we give some clotting factors to improve the coagulation? It seems rather not, but there are some discrepancies in the studies. So this is with Australian snake venom induced consumption coagulopathy, and the authors said that early factor replacement may be associated with some improvement in the coagulation factor. But in this study with Chinese snakes, it's the opposite result. It appears that no improvement was observed in coagulopathy profile with these snakes in patients receiving clotting factor replacement after antivenom administration. So there are some uncertainty regarding the value of administering clotting factors, except of course if there is some rare situation just systematically to compensate or to improve the coagulation situation. Sometimes the patient may present some particular aspect called thrombotic microangiopathy, thrombotic microangiopathy. Here also there is systematic review, and it seems that there is no evidence to perform plasmapheresis in these patients for improving the situation. So it seems that particular aspect of impairment in coagulation and hemostasis is refractory to these pharmacotherapy interventions. The last point is, of course, to discuss some ethno-medicinal plants, because these are largely used. Maybe the most important studies published, even if I don't know anything about that, are regard this kind of plants and treatments, because they are supposed to act on different targets, inhibiting the enzymes present in the venom, reducing the oxidative activity of snake venom, having some anti-inflammatory properties, chelating some deleterious metals, and so on. And of course, if you go to in vitro studies, you have very precise studies. And this is like an overview of these regarding the inhibition, exact inhibition of some snake venom compounds by some vegetal compounds, and of course their potential effects of herbs on venom consequences in organs. So theoretically it is interesting and there are some potential. And of course, if you go once again to real life, you see that, especially in Africa, almost all the snake envenomated patients are treated with ethnomedicinal plants. These are the most prevalent adjuvant pharmacotherapy agents that are used. And you see that these plants, herbs, comes from different plants and are administered from different way, by topical, oral, infusion, chewing, and different parts of the plants are even used in the preparation. So that makes this field very complicated to investigate. It's probably between some part and another in the plant, the exact composition is completely different. But this is also the case in Central America, so it's not just Africa far from us, it's also in Central America. And it seems, based on this study, that at least 208 plant species are traditionally used in Central America, even though there is no support, no scientific support to evaluate their safety and efficacy. And I let you read different plants, I don't know them, but it seems that some of them are more used and they are more present in some traditional remedies. But something important also to consider when treating the patient, and this is like something new, I think, is the mental health of the envenomated patient. And this is an interesting recent published study from France. So I wanted to put it forward. They investigated the parameters associated with the delayed recovery. Of course, some usual parameters appear, like severity of the bite, lower limb bite, gender, the female gender, the inappropriate treatment, the time to hospital admission, but they noted the importance of some psychological factors. For instance, 1 year after the bite, they observed that 15% patients, treated patients, avoided the activity during which they were bitten. 5% still thought about the bite, and 38% were definitely afraid of snakes. And they suggested that these psychological aspects significantly impact the recovery and influence the persistence of prolonged sequela, and encourage to give some therapies, adjuvant pharmacotherapies, even very soon to prevent and to improve the outcome of the patients. So my take-home messages are the following. Of course, all of you understood that antivenom, if available, remains the mainstay of snakebite management and should be administered as rapidly as possible, especially in the most severely unvaccinated patients. But it seems that there is a place, a room for different adjuvant pharmacotherapies to improve the outcome. Some of them are recommended, like low-dose epinephrine to prevent antivenom-related adverse effects, analgesics from acetaminophen opioids, antibiotics, even though they should not be systematic, and they should be directed mainly against Staphylococcus aureus and Enterobacterium. Local site therapy is photobiomodulation and pulse ultrasound therapy are also interesting. And of course, you have to give supportive care for organ dysfunctions and update tetanus status. But other therapies are completely discouraged. You see the level of evidence remain relatively low, even though you have some systematic meta-analysis. Those therapies are heparin, corticosteroids, ethnobotanical and herbal remedies, and phagocytosis. So thank you very much. Please do
Thank you very much, Bruno. So we have time for questions. I have one.
Yeah, of course.
What is your opinion of this? Since we know that the particularly severe snakebite envenoming is associated with systemic inflammatory manifestation. How about using some of the therapies, for example, sepsis or other type of disease associated with systemic inflammation? You foresee some possible connections there?
Yeah, sure there are connections, but even with sepsis, due to the complexity of the mechanism involved in this cascade of inflammation, there is no therapy that was demonstrated as effective to reduce and improve the outcome. So till today, there is no clear anti-inflammatory or drug that we use. So because the mechanism is complex, if you try to inhibit or to block one pathway, the system will be activated by other complex, numerous additional pathways. So till now, it's very difficult. But probably in the future, combinations of drugs. But you're right that this systemic inflammatory cascade is important. Even though probably at some level it's important because it's a balance. If you completely inhibit inflammation, the bacteria so you have to inhibit it at the right time. And now there is no effective drugs to sepsis, to my knowledge, that is effective.
I have a question. Several hospitals, there's a tendency to perform a lot of
Yes,
and physicians are like scared.
yeah.
So where do you draw the line?
Right. That is difficult. I think this is really based on the experience of clinicians at the bedside. So I have no sufficient experience, but what is important first is to characterize, exactly diagnose the compression by measuring the pressures within muscles. That is not so difficult. And then, of course, balance between the risk of sequela dysfunctional and the advantage of improving circulation. So if everything is already closed, I think there are major risks of super infection. So I would not recommend. But if it is still at an early phase with edema and nerve compression, then they need some. But since that is performed probably too much, even in the US, and the authors who studied this field do not recommend that. At least systematic fasciotomy, if there is some compression, is not recommended. It's better to improve the administration of antivenom, improve the fluids, the antibiotics, general treatment, critical care, rather than surgery.
And since not you yesterday, our friends sent share in the early stage of the something to include in the
Yes, the aims of using corticosteroids initially is double. First, to reduce the adverse effect of the antivenom. It seems clearly here you have good level of evidence. It's not useful. Only epinephrine, low dose of epinephrine may be effective. So for this indication, no. For the other, which is to alter the septic-like reaction and to reduce the inflammation, there is no clear study, no randomized study to my knowledge. So I will encourage studies, but when you read some general reviews, nobody suggests to use corticosteroids, at least high doses of corticosteroids to control immunity and reduce and improve the outcome. It's not recommended, but like in sepsis, it's an eternal question. Even though in the bacterial sepsis, there was still no definitive response, and some years you have to use corticosteroids. If you don't use them, you are a criminal, and the year after, you have not to use them because it's forbidden to deteriorate the situation. So there is no definitive position. Because once again, it's a complex system. And here, by the opposite to all those specific molecules, corticosteroids act on so different targets that they may in some cases improve and others deteriorate. So it's not clear. No, there's no. In the objective of improving the final outcome, there's no study. But in the objective of reducing the adverse effect of antivenom, yes.
Last question.
My thing is, I understand what's clear about the steroid, but sometimes patients present steroid. Patients present with spasm. Isn't that an indication or relative indication to use the hydroxyl to train a snakebite? It's not being used routine by us to manage routine like legal response to management. But it is an indication that looks like high dose but then it does come with spasm, that sort of thing.
Yeah, I agree with you. That means that for specific indications, there is a room for corticosteroids, of course, but the systematic infusion of corticosteroids in the objective to, uh, uh, to alter the course of the inflammation, the systemic inflammation, there's no clear evidence for that. But of course, in specific situations, and I show here the late complications with anti-serum or with antivenom, there is an indication of corticosteroids, and you should, of course, based on if you have a bronchospasm, if you have urticaria reactions, there's no discussion. But not, to my opinion, that I have no experience, not to give this systematic in the idea to improve the consequence of venom. Yes, yes.
Thank you very much for.
There will be a consequence. In the case of, when in the case of Natusha, Professor Gutierrez and I, the protocol was when I was filling down there was everybody is able to do what they want in their country. There was some modification of the protocol, and our protocol we never advocate the corticosteroid. So the reason in St. Lucia, some doctors say that we use corticosteroids for preventive measure, but it's not something internationally we use, even for anti-inflammatory effects, even for otherwise. So we are not the Prime Minister or Minister of Health in St. Lucia. I think they can do what they want, but in the international aspect, all papers, medically, they don't. As you said, corticosteroid, this doesn't have any space in the management of snakebite.
But all what I said still require higher levels of evidence because it's based on retrospective studies, small studies. But there are some agreements about that. Thank you.
Thank you very much. Please come back in about a minute. Yes. Sure.
Okay, let's continue our journey. Now I am going to introduce Dr. Andrés Hernández with the pharmaceutical group of Instituto Poder Vital, and he will present the production of antivenoms for Snakebite Envenoming at Instituto Poder Vital y Costa Rica. So, first of all, I want to welcome you to the Instituto Poder Vital. I know some of you are just passing by here, just these 2 days of symposium, but we are always open for collaboration for this kind of efforts that actually end up in research, in development, in teaching work, in everything that is not only about production, but about a great effort towards getting patients, getting snakebite envenoming solution. So the presentation is not going to be about how we do antivenom, as you all kind of know the process, how it is. It's most about it, but it's also about what the things that surround production that make antivenom available at this no country. The efforts that we do in teaching and research and development. So let's carry on. So in that note, I wanted to talk about how doing an effective and safe antivenom is not only on us, on the ICP as a producer, but in terms of Costa Rica, it's also on the health regulatory entities, such as the Ministry of Health of Costa Rica. We also have entity for veterinary production, the Caja Costarricense de Seguro Social, which is Social Security, in charge of the hospitals and distribution of the product in all the hospitals, including Costa Rican hospitals. And also have the firefighters involved, as they are the ones that have to attend management of snakes in houses and take them out of houses and prevent accidents. And we also have the Red Cross, which I have kind of an actual situation that I wanted to point out at the end of the presentation, because we kind of did a new contract with the Red Cross to get them antivenom, so they can manage to get to those rural places where we cannot access, where the hospitals cannot access, and get antivenom administration and save people that, as we mentioned in other lectures, it's probably not available, or not available as soon for them. So that's about it for product in terms of outside, but internally also we have several sites or sections from ICP that also carry a lot of weight in doing the product that we have. So we have the production as well, but serpentarium, where we have the management of snakes, the horse stable or farm, where we manage to have all our horses that we immunize, dietarium, quality control, which is very important aspect of all the production process, research and development to produce new antivenoms, as well as make better antivenom of the ones that we have. Social outreach, which is getting to the communities, getting to the hospitals, to everyone, to get them involved. And research, which is kind of what most have been talked about. It could be about toxins, it could be about movement of snakes, it could be about a lot of things, but it mainly focuses on knowing how to get to a solution. Quality assurance as well, and administration, which is part of what we do to get this product to the community. So just a little fact, because there's been a long-standing production. Since 1967, it was the first fully available antivenom done for specific for viperids in our country. And from then, the institute was then founded in 1970. And in 1972, it was part then of the University of Costa Rica, which is kind of a big part for what we do nowadays for the social outreach and the social responsibility that the institute has. This is just like a fun memorandum or a letter from the to the rector of the University of Costa Rica from that time, just to acknowledge the fact that it was a very important historic event in having the first batch done here in Costa Rica, and then from then on the institute will carry on. So, just to talk a little bit about the production, we did this image in some years ago to basically kind of explain how all these sections that I just mentioned get involved. We have a bioterm. Let's see, we have like the life cycle of a vial or of a production batch. So we start with the bioterm because we need the husbandry of lab animals to do animal models for testing and preclinical studies. From then on, we can do also research and development in terms of designing new antivenoms, as well as preclinical evaluation of those antivenoms, and improving the manufacturing technologies that we already have and products. Also, we have a serpentarium that it's really important in establishing and maintaining the venom, let's say the venom pools that we have for production. We also have our horse table, which is where we have management of plasma. We immunize horses and take also good care of those horses because those are the first labs, you could say, where we are getting those antibodies against the snake toxins. So we have a lot of we have in really high importance the fact that the horse care and healthcare of them is really important in terms of getting the best product possible. Also, then the production facility, which is in charge of management of clean rooms, sanitization, water for injection production, antivenom purification, formulation, stabilization, bioactivation, filling, packaging, and getting the finished products done. And quality control, which, as I mentioned, is part of every step of this process in terms of knowing what quality of materials we are working on, what quality of process we're doing, and the finished product as well. Then there is distribution, quality assurance, we're getting good manufacturing practices, quality by design, and risk assessment and traceability. These are some pictures of what we have been doing the last couple of years. We have new infrastructure in terms of the dietary, which is right here. Also for the farm, which is kind of 30 minutes from where we are now. We have new also infrastructure to take better infrastructure to take care of those horses, to management of immunization and bleeding processes. Also, we have new installments or equipment and to do for the serpentarium, for the houses, let's say, of the snakes, and for extraction, as well as new protocols in terms of management of care of those snakes and management and care for horses. And also, these are some of the pictures for the production of snake antivenom. You can see their plasma. This tests on newer equipment. Also, the semi-automatization of the processes in terms for better clean rooms, better care for the product, and also the lyophilization process for the products that we have. So just getting into the products that we have in the institute, there's the polyvalent antivenom, which is for the American continent. It's effective against the venom of snakes such as the pit vipers, birdlines, rattlesnakes, and members of the viper family. It has been tested against a whole lot of venoms, almost more than 40 snake species from the Americas. And it's unique worldwide because it's backed up by 4 clinical studies done in Colombia over the last 20 years. As distribution countries, it's mainly Central America and some of the Caribbean as well. We mentioned Santa Lucia, for example, Trinidad and Tobago, Belize, among others. And currently, there are efforts on the way to expand its coverage to include more snakes, which could mean being also for the Caribbean. We have 2 pharmaceutical forms here, liquid, which requires refrigeration and has a 3 years stability, shelf life, and it's in a 10 milliliter vial presentation, as well as the freeze dried, which doesn't require refrigeration, has 5 years shelf life, and it comes with its diluent or solvent. So these are just to focus on the clinical studies that we probably can't read them, but those are the clinical studies that have been done with the polyvalent over the past 20 years. Also, some epidemiology or getting results from clinical efforts to see that, for example, in Ecuador, the product has turned out with protocols and everything to get deaths to 0, which is something that's very remarkable if you look at the past photograph for all these countries in Latin America. We also have the coral antivenom, which is also for the American continent. It's effective against Central American coral toxins and some South and North American corals. Thing is that there's a lot of coral snake and species in South America, so not all of them have been tested out. Basically, has also one of the largest, if not the largest, coral collection. And this is also Central America. Basically, is the distribution countries. It does have a liquid pharmaceutical form. Turns out that for coral snakes, there's very little snake-bite venom cases. So doing this product is really difficult, keeping it. And then there's also the fact that there is not that use. So we do mainly probably a batch per year. So it's really difficult to maintain this kind of production. But we manage with this liquid, which requires refrigeration, has 3 years shelf life, and 10 milliliter presentation. As I mentioned, there is a wide variety of species of variable colors or color patterns, especially in South America. And now we also have an antivenom for Africa, Equitas Plus ICP. It's for sub-Saharan Africa, effective against venom for a wide variety of snakes, especially the carpet viper, the puff-adder, and the black-necked spitting cobra. There have been quite an important partnership with Doctors Without Borders and Medicines Sans Frontières that has expanded its use to many countries and has generated a lot of clinical reports and a very big effort in terms of getting to know the product and getting to know that it's as effective and as safe as it is. It has the largest clinical study of any antivenom is at the time. Distribution countries, you can see Nigeria, Burkina Faso, Kenya, Ghana, Cote d'Ivoire, and Africa Central Republic, and others. Also, it has just a liquid presentation, which is something that we've been doing also another product, the Lifelice product, to get into rural places where probably a liquid refrigeration is probably a problem. The aim also is to cover the venom of more snakes from the latter family, such as the spitting cobra. This is the clinical study that I mentioned before. It was done in Nigeria against the carpet viper. And so this is kind of some actual success examples that I wanted to bring out. I wanted to point out the fact I just kind of changed this yesterday, given the fact of the lectures that you've given, because I wanted to mention the part of the availability of the product
And we recently, as University of Costa Rica, did a contract with the Red Cross to get them the antivenom, and so they can get to those rural places or indigenous regions where probably hospitals are not getting to, and get the antivenom properly and administered. So as you can see, this was even from November, which is just like a month ago, and we just did like this kind of lecture or teaching process to get them to know about the product, get them to know about how it is administered, about the certain issues about it, the problem of snakebite. And just like 1 week ago, it was the first time that the Red Cross used the product on someone in an indigenous region that he couldn't get out, and the hospitals couldn't get in. So they managed to save someone just a week ago, which is kind of amazing and very good news. I just wanted to kind of bring the example because I'm very positive and sure that this can be like repeated. Also, an actual case that's happening, as I mentioned, is that we have a freeze-dried antivenom for Africa. This is currently under registration. It had a development phase where the antivenom was ready for industrial scale production, and it is a freeze-dried, and it's a presentation of 10 milliliters with a solvent or diluent, and it offers the advantage of being freeze-dried, as I mentioned, so it doesn't require refrigeration and has a shelf life of 5 years. Well, it's going to be because it's currently under development, so the stability study is pending those 5 years, but it's currently at 4 years, if I remember correctly. It's designed to be effective against more than 20 types of venoms, poisons, and venoms. It is currently in the registration process and has shown very positive results in preliminary studies. In fact, we got that product to Swatini, which they managed to use the product in 2023 to 2024, in the summer of 2024. And basically, they had this very good news that they had 0 death cases, which it was like a surprising event, as they kind of had this number around, I don't remember correctly, but around 50 maybe or something like that. So in delivering a product that was effective and safe, and seeing the news also for our staff, seeing the news from the doctors themselves that we were saving lives, that this was a case, this is another case, it was really motivating and really, really positive for us to know that this is what we are working for. This is our effort. What are other forthcoming purposes? Well, in the Caribbean experiences that we were having, we are doing efforts underway to expand coverage to include more snakes from the Caribbean and South America. This depends on gathering clinical experience, as you mentioned yesterday and today. Preclinical assessment of neutralizing efficacy for the antivenoms against venoms of snakes from the Caribbean, which has been partially done, and also work towards the best formulation for Latin America and the Caribbean. And in terms of other regions, we are doing an antivenom for the Middle East and North Africa, a product that kind of is different from the ECTAP. It works against different venoms, so would neutralize this product. It's currently in stability, and it's pending different parts of the development process, but it's already done certain batches, and something that's what we're working on. Also, a product for scorpion stings, for the Middle East and North Africa as well, which is kind of a big problem also over there. It's something that we've been working on in research and development. And yeah, also the forthcoming remodeling, currently remodeling of the production facilities recently started this last 2025 period. It will provide improvements to the production plant, provide larger spaces, and improve material and personal flows, and provide the necessary space for the development and implementation of newer technologies. So With that, I want just to kind of give a gratitude to all the staff that makes this possible. And that's it. Questions?
Thank you very much, Andres. Any questions from the audience? Yes. On this presentation, I have a question about the polyvalent experiment. Yeah, that we provide for all Africa, the polyvalent including the brain and the fish. Do you see more adverse reaction than the wild polyvalent antivenom in comparison with monovalent antivenom?
I think we've seen the same kind of adverse reactions. The percentage is kind of the same as the one that we have for polyvalent here. Or yeah, I know there's something to add up, but I think it's really comparable.
Yeah, I think they're comparable because the protein concentration is the same. It's just that we use more venom to elicit right there and the results. But this new antivenom, I think, has been tested basically in Swatini, right?
And also it's been used in South Africa, so the newer the life was from the Israel.
As far as I know, the information that we get from the systems in the protein indicate that there is no higher scale.
But you're right in pointing out that adverse effects is something that these medics physicians kind of have this thing where they in the past probably had products that really had very bad adverse effects, so their expectancy is to have a lot of trouble on the products that they get. So I kind of get by or see that there's a lot of taking care into using newer products in different regions, and it's understandable. It's also how it should be done. Most of these products are done exactly the same formulation, exactly the same kind of protein, the amount of protein, so they should compare the first effect on their foods. It's not the same product. It has kind of the as comparable, let's say, profile, because it's some of the snakes that are in the liquid presentation are in the lyophilized product. Preclinically and what we've seen clinically, it kind of manages to be exactly the same for the same species, but it turns out that it also has antibodies against other toxins from other species. So it might have a wider scope than that product. It probably definitely has it, as a lot of venoms were involved in the production process, immunization process. So it's not the same. That's why we are kind of doing this even different names, because it's kind of a different product. Whereas in the polyvalent that we have here in Central America, that we use here in Latin America, is mainly the same product. It's just a presentation or a lyophilization process that is added to the production process.
When you do the registration, it's a different product.
Yeah. Even if the polyvalent here in Costa Rica is the same as the liquid is the same as the lyophilized, and we have to do like kind of a different registration. I understand that there's a way to do it kind of as the same product, but we kind of work mainly because we've done it as that so far. We work as liquid for one registration for liquid and one registration for lyophilized. Should have clinical data, yes, because it's not going to be or shouldn't be enough for just clinical data to compare a product with the other, especially if there's immunization schemes different and the process is different. Yeah, however, I don't know if the works that way because there's really little clinical evidence for lots of venoms. But yeah, it should work that way, that the clinical evidence should be there in order to register.
Yes, yes, very good presentation. Solution. So, have you ever been this ICP to chart? You have some work. So quickly go from the manage. To just try to work.
To test the work? And where? I can't really.
In the preclinical study we did with the previous regional program, it was evaluated with Yaranaga several levels and several modes. And it does neutralize with Yaranaga, but with lower potency compared to the Brazil.
It is part of the 4 events that I have said that polyvalent has been tested out against. So some of them, most of them are from the South American region, as it was part of the CTED program that carried out like 10 or 15 years ago.
Thank you for the presentation. One way that the celebration is happening on Costa Rica. And I think that there's considering an island, there is improved our reporting. To include zero reporting on side effects, as well as the area of reactions. But I'm looking from your end, since you are suffering to any other islands and etc. Do you have any requests to these countries that you send on mandatory reporting? And if there's difficulty for them to send the information, also includes zero reporting, or zero reporting for reporting, there's nothing happening, then you may look into incentivizing them, and maybe give them a discount when you have to use that regularly as requested. Do you do that?
Yeah, we have from vigilance and part or section where we want to kind of address this because there's actually very low reporting in terms of how the antivenom carries out. It's difficult, but we have to kind of get to somewhere where we kind of have a meeting or more direct talk with people that are using the antivenom to get them to kind of see the importance of pharmacovigilance, to get those reports, to get those, because that kind of sub-registration problem that we have is not only sub-registration with cases or snakebite cases, it's also sub-registration with adverse effects, with like the they adverse effects and everything. So we need to have as an institute to make that more of an issue, more of an important case, because I think we've done just in the media. We have the form, we have in the webpage the way to report, but I don't think we're doing enough to get the message through, to be direct, to see the importance of that. So it's very important that you pointed out, and we definitely have to.
I think if you mean because a different rank within the model that is an opportunity to save money on a drug, and that brings already on the private. I think that's what we do. Possibilities come together and move on.
Yeah. Yeah, no, that's a good idea, and we definitely have to look into ways to doing that, make that possible.
You use the cost unity, because there's been nothing that. How do you determine the efficacy with this cost unity? Is it logic? Is it because of the week of the results? Who will determine if it will be?
Yeah, I think that's done after the production because there's so much different species that have to get being covered or trying to be covered that we do the production as we have done it throughout the years. And basically, we do the preclinical assessment different times in seeing different activities, also follow up of the everything. But I think it's not something that was born from that, rather than with the product itself, getting to know it, and then seeing if we can do changes in the immunization scheme or with the toxins that we have to apply to the scheme and get that product to maybe be better. But in terms of probably how Costa Rica is a bridge to South and North America, probably provides a better place to do this kind of antivirus where we have a better or a good neutralization against a lot of species.
If I may, yes, every time we introduce an antidote to the before that, we do a thorough preclinical assessment, limits, evaluation of the lethality, hemorrhagic activity, overwhelming activity, toxic activity, and activity, a couple of enzymatic activities. So with this preclinical information, we move on. But as we correctly pointed out, there is the clinical evidence to observation of the study. In Colombia, there have been clinical trials carried out by a group of trials in the past. But the evidence supporting the use of envenoming in Peru and Ecuador, for example, basically pretty. And there is, of course, clinical reports of people also saying that and so on, but not formal clinical studies.
But that's why clinical reports and all this information is really important because carrying out a clinical study, for example, for the coral snake, which is just 6 cases here in Costa Rica per year. If you are asking for 1,000 cases, it's not going to be feasible. And even getting those, like doing a study in one hospital, it's going to take you to have just one, maybe of the 6 cases of the year. So it's a really challenging thing to do, and that's why reports and getting this clinical evidence is really important. Not only for the main, even snakes, but even make a point that every snake that you're saying it's being neutralized should be given information about the clinical status of the efficacy and safety. But it's kind of an issue that we have to go with.
Sure, clinical testing is very important. We have been discussing it in the Panama. We and myself and other colleagues were including the meetings of the Pan American Health Organization. I don't know if we would like to make some point because traditionally the gold standard for clinical trial is a random controlled, randomized, double-blind clinical trial. This is very difficult. Expensive and complicated logistics. So this meeting in August in Sao Paulo, we were discussing observational, prospective observational studies that would get information on the safety. I don't know if we would like to comment on that.
Yes, just as manufacturers, Even after antivenom is available. So we are used for phase 4 post-transplantation study. And this team require the something, but I think it will be, of course, but innovation certain kind of studies. Not as to be, I don't know the result of the elections. This opportunity to together have a lot of confidence that could be a kind of thank you for manufacturers, terms of the actions, or even changing the
So, all of this, process.
provoking. Finally, should do, because if we, when we are updating, for instance, the insert, we need to have scientific evidence for each modification of the regulation. So if we do not, it will be a little bit
So, an observation study would be, for example, one hospital. You get a standard protocol and you follow up the cases. Yes. Yeah. The current purpose on the obligation. We have to start defining
seems and prepare all it's better than nothing. We have to and realize they are bad. We don't need
organization. This is what you want to do in
Yeah.
topics.
but we manage for issue by these ICT or and if we want to use your as a value for we should validate everything that and we so it is possible not to but there are some multi guarantee the funds of data.
The question? Any question? Yes. If I understand well, is this answer on using neutralization? Because it's true. We think there is a big advantage from this. Resume very nice. The robustness of the configuration of the specific considerations. So I would know that there's no risk like this. It's a way to improve the confidence we have in the robustness. Some people are arguing that the standard test acts accepted by WHO is incubation. But yes, I think this rescue type assays will provide further assurance that all this effect.
In my understanding, the experiment under the patient, they can be sent into the true bacteria before giving the bacteria.
Thank you very much again. Okay, and the last talk of this morning is by Dr. Alcalde of the University of California on snakebite related infections. Yes.
Good morning, everybody. So, I think this is a challenge topic we have Jacqueline with the audience to work on the topic. What your heavy topic? Infection following snake bite can occur in 77% of cases. So very, very huge interval. Why is difference? Because there is no uniform and standardized definition of infection following snake bite. And for this, we can get some studies who define infection on clinical parameters, sometimes only on fever, and other who define infection based on antimicrobial samples. So we have a huge difference, and in our unit, we already published it in 2022, our result on infection following snake bite, but those are updated results of this year. And infection occur in 35% of cases, third of cases. Curiously, it occurred in a median delay of 7 days. And we didn't understand why this delayed expression of the disease, why it comes very late in the course of the disease. All of us know that the incubation phase of bacteria to get from inoculation to infection is 48 hours. In this case, we have 7 days, and a lot of articles in the literature report similar results. So why? Probably because the quantity of bacteria inoculated is very small, and as the venom will attack the muscle and the skin, this will prepare a favorable environment to the growth of bacteria, and this very small amount will need time to express infection and to significant amount of threshold to express infection. In clinics, pain observed 100% of cases, erythema, abscess, necrosis, cellulitis, necrotizing fasciitis. But some of these symptoms are also the expression of the envenoming. Sometimes we don't know the symptom is related. Envenomation, you showed us yesterday many image and photo of
of a local manifestation of envenoming, which are similar to infection, but they are not infection. But in some cases, when there is abscess, maybe we are sure, the abscess we are sure is infectious collection. But even necrotizing facades can be related to the venom itself and not to bacteria. When you analyze the frequency of the secondary infection, depends on the grade of the envenoming. We can see that there is 30% in grade 1, 38% in grade 2, and 50% or more in grade 3. That means that probably the local condition and the injury caused by the venom is the bed of infection, and not only the bacteria injected in the skin. The other information that in grade 3, we have patients with necrosis, but also we have patients with renal injury without any local manifestation. They are also counted in grade 3. But if you report the number of affected cases, the number of cases with local infection, you get approximately 80%. In multivariate analysis, the bed of infection is necrosis and blister. The bed of the infection is the local injury caused by the venom. In our study, microbiological documentation is occurring in 2/3 of cases. And the main isolated bacteria are Aeromonas hydrophila, Morganella morgani, and Proteus rugerati. Both of them are Enterobacteriaca. This one is not a non-fermentative gram-negative bacteria, and this one is group 3 Enterobacteriaca with capacity to produce AMP enzyme. We have a lot of other bacteria which belong to the Enterobacteriaca family. Curiously, the same bacteria are also isolated from the mouth of the serpent. And we think, but we're sure, that the mouth of the serpent is contaminated by the fecal flora of prey, which may defecate when ingested by the snake, and also by the environment regarding Aeromonas hydrophila, which is an aquatic bacteria. So both of them prey and environment which will contaminate the mouth of the snake, and the snake, when it introduces its fang, it will inject bacteria, and this bacteria, even in small quantity, will take time to grow, especially when there is necrosis and blisters, and will develop infection, secondary infection in a median delay of 7 days. So we try to respond to 4 questions. The first is regarding the systematic antibiotic use. The second is about the empiric use of amoxicillin clavulanate. The third is the most appropriate antibiotic to use in case of secondary infection. And the fourth is about the duration of infection control. So for the first question, last year we commented systematic review of the literature in the American Journal of Tropical Medicine and Hygiene, and we published it with editorial, where we say that there is no evidence for the effectiveness of routinely administered prophylactic treatment. There is no evidence. If you remember the epidemiology, infection occur in 10 to 90% of cases. That means that in 10 to 90% of cases, there is no infection. That means that when we put systematic antibiotics, we have almost 90% of cases to make the wrong decision or prescription. And the second point is that empiric antibiotics can be used in targeted cases. What are these cases? When there is necrosis, when there is blisters, when we see that there is some inflammatory signs, even if we can't make the difference between signs related to the envenoming or signs related to infection, and all of us know that early antibiotic therapy give best results than delayed antibiotic therapy like antivenom. So we can't put antibiotics in these cases. In our hospital, this is the frequency of cases who receive antibiotics on admission. And you can see that we made an extensive information campaign, and we made a lot of power to inform, to discuss, to train. And in 2024, we had zero prescription antibiotics at admission to the hospital. And this is a great result. So what about empiric amoxicillin clavulanate use? Amoxicillin clavulanate is recommended to prevent infection after an animal bite, according to international infectious society like ITSA or an international international society of surgeons. But these recommendations are based on studies involving dogs, cats, and human bites, but not snakes. So there are wrong recommendations, and we have not to follow this recommendation. Just to remember, what are the most important microorganisms causing infection? Aeromonas hydrophila, Morganella morgani, both of them are resistant to amoxicillin clavulanate. This is yours. You can comment. You can comment. Okay, so Jacqueline conducted this impressive study where she randomized 93 patients to receive amoxicillin clavulanate to 94 patients who were the control group and didn't receive amoxicillin clavulanate, and she found that there is no difference in number of patients free of infection, and she concluded that preemptive amoxicillin clavulanate for preventing secondary infection is not efficacious. I didn't change your message.
Yes.
Okay. 2020, with double easier, we published this editorial in Journal of Venomous Animals, including tropical diseases, and we say antibiotic administration should be considered in severe cases with severe local signs, in those having local or general signs of infection, regardless of the degree of envenoming. And the last phrase in this editorial was empirical antimicrobial agents should no longer be considered in this context. So it's not the first time we repeat this message, and we try to explain why. So this is another Brazilian study from the center-west Brazil, and you can see that they investigated more than 300 snake bites, half of cases developed infection. Only 5% of cases had soft tissue sample or microbiological sampling, and amoxicillin clavulanate was used in half of cases. I think that this is a high frequency, this is a very low frequency disease have no longer to be used. But this was 2 years ago, maybe they have changed. It's your team? No, it's not you. This is the map of antibiotic use in French Guiana for the overall population. And you can see in patients who didn't receive or didn't develop infection, 1/4 of them received amoxicillin clavulanate at admission without any proof of infection. It was right. But today, today in 2024 and 2025, 0 patients received amoxicillin clavulanate at admission in French Guiana. And in patients who developed secondary infection, most of them received also amoxicillin clavulanate as empiric therapy and amoxicillin clavulanate as definitive therapy. We investigated this file one by one, and I think that as this population is the sum of all patients and new patients, I think that this quantity of amoxicillin clavulanate use will not be the same in the next year, and it will decline. But one important thing is that we start using cotrimoxazole to prevent or to treat secondary infection, and it works. And this is a very nice result for us. I will explain you why. So this is an alluvial diagram that shows that patients who started with amoxicillin clavulanate finished with amoxicillin clavulanate, probably because there is no antibiotic reevaluation during the course of antibiotics, and so as for penicillin, tazobactam, Thirogenius and cephalosporin. Patients, the definitive antibiotic therapy is almost similar to the empiric one. So if you make the good choice at the beginning, you are sure that you make the good choice for the rest. Third question, the most appropriate antibiotics. So return to microbiology, we have something which is active against Aeromonas hydrophila and against Morganella morgani and other Enterobacteriaca. One of the molecules that we recommended in our editorial is cefotaxime. Cefotaxime is active against Enterobacteriaca group 1, 2, 3, and active against Aeromonas hydrophila. So this could be a very good, very nice option. In our hospital, this is one of our latest publication in the microbiology spectrum. We investigated the MIC, the minimal inhibitory concentration of Aeromonas hydrophila to cefotaxime, and we thought that it is very low, and it is lower than the breakpoint susceptibility by the EUCAST, the European Committee on Antimicrobial Susceptibility Testing. So amoxicillin cefotaxime could be a good choice. Those results are similar to others from Korea and from Australia, and we think that cefotaxime can be a safe option. Another result regarding cotrimoxazole. All of strain of Aeromonas hydrophila were susceptible to cotrimoxazole. And that's why we introduced it in our practice last years, because this could be a good option to treat snakebite-related infection, because it's rapid absorption from the digestive tract, almost 85 to 90%. It has a very wide spectrum of activity, gram-negative, gram-positive, and also non-fermentative bacteria. There is an effective penetration into the skin, and the concentration of cotrimoxazole in the skin are very high, and sometimes they are similar to those of in the blood. It has a bactericidal action, and cotrimoxazole acts on the DNA synthesis of the bacteria, and it is bactericid. And it has a very low price. 20 tablets of cotrimoxazole in French, they cost between 5 and 15 euros. That means that less than 1 euro the tablet. And it can be effective in remote areas. You don't need to make injection. And we can see that half of cases in southwest Brazil received cotrimoxazole as first-line antibiotics. So this is a good option. And I think that we have maybe as we think about promoting randomized controlled trials for antivenom, we have to do so for cotrimoxazole. So we already seen this, and you can see cotrimoxazole in our practice is used as a definitive antibiotic rather than an empiric antibiotic. The first question is the duration of antibiotic course. There is no data in the literature, and you can extrapolate about dermatitis, cellulitis, hepatitis, cystitis. The recommended duration of antibiotics are between 7 and 15 days. But regarding snakebite, we think that 5 to 7 days are sufficient. Why? Because almost in all cases, you need surgery. Almost in all cases, you need to make some local debridation, and this can help to reduce the inoculum of bacteria and to shorten the course of antibiotics. So in conclusion, first, there is no evidence for the effectiveness of routine prophylactic antibiotics. Second, the empiric antibiotic can be used in targeted cases, mainly in cases with severe local damage. The third, the most appropriate empiric antibiotic is piperacillin tazobactam, ciprofloxacin, virginiacin, or cotrimoxazole. This is a very good molecule, and you can use it safely and efficiently. The first-line amoxicillin clavulanate should no longer be considered. No first-line amoxicillin clavulanate. Once the microbiological results are available, de-escalation is necessary. And I showed you in our practice, in the alluvial diagram, there was no de-escalation, and we have to work on this to improve our practice. And finally, efficiently managing snakebite envenoming requires safe and effective antivenom, but also appropriate and available antibiotics. Thank you very much.
Thank you very much, Anthony. We have time for some questions. Yes.
this case. So I think some very positive conclusions of that. Probably each condition no exact.
Yeah. So, the infections can occur when patients are in the hospital, or it can occur in the community setting. When it occurs in the community setting, there is no reason to be the reason to find resistant bacteria. No, when it comes in the hospital setting, where we can have a different flora. One of the arguments to use petroxyzole, right, is that it is a wide spectrum antibiotic, and it is effective also on Pseudomonas. And in our hospital, when we isolated Pseudomonas with multiple resistant profile, almost in 70% of cases, petroxyzole remain effective. And it represents our salvage therapy, so even in a context with wild type bacteria or multi-resistant bacteria, I think that petroxyzole can cover a very wide spectrum of microorganisms. And we can use it safely as analysis, but probably we can apply to build the collaboration and the colleagues, and probably we will have to do some study. But there's three cases of bacteria to cover. Enterobacteria, some gram-positive like Staphylococcus, and if the snake feeding in the wet of the under iron receptor. We cover this, we cover more than 90% of the responsibility.
Is diagnosed because of this information about the now the symptoms about the venom or symptoms about the skin. Do you have some criteria or the training or protocol that is a good for the quality or assistance? Is it known for the manufacturing? What's this?
It is a panel of criteria, set of criteria. First, when patients arrive with necrosis, already very early necrosis, blisters, and if there is some cellulitis, we give antibiotics, independently of fever or not. Give antibiotics. The second criteria, very important, is that sometimes the symptoms arrive with the second time. That means that the patient arrive or the victim arrive with symptoms that may resolve during the 2 or 3 days, first days, and after that, the symptoms reappear or worsen. So, in that case, especially when there is fever, major reaction, allergic reaction, like CAP, so it is a two-time history, including and working data, general and biological signs, and local damage, including many toys.
I have a question. Anaerobic bacteria. What have you found in the literature regarding anaerobic bacteria?
Anaerobic bacteria is a very difficult diagnosis. And in the clinical practice, our diagnosis of anaerobic bacteria was essentially in case of blood sample or the environment adequate, or in case the patient or death. Otherwise, we cannot confirm or confirm that there is no anaerobic. This is the same challenge for all the practice regarding.
So how about the selection of antibiotics? If there is an anaerobic effect, will we consider antibiotics?
Much better the reference.
They have been involved in research in collaboration with doing a metagenomic analysis of bacteria present in the mouth of the snake, in the venom, and in the venom gland, because it has been believed many years that the venom in the venom gland is sterile. It's sterile, yeah. But with these metagenomic techniques, they have identified bacteria in the venom gland, which is quite common.
So, the last metagenomic has not as friction, which is maybe 200 or 300 times compared to what we know before. It is impressive, and we have a number of clinical conditions that had never taken action, no microorganism, even if it is natural, so I think that
But there's no more questions. Thank you very much to everybody. Thank you very much for the speakers. And this afternoon, yes, so we're going for lunch now. We go back 2 o'clock. We will have a presentation by Juan Jose Calvete. It will be remote presentation. And after that presentation, then we will go tour, so to speak, to our institute, to the research laboratories, and especially to the secretary, where Aaron will host you. And then at the end of the day, we will have like a round table to round up some of the discussions and reach to some. Let's go for the lunch. Ya que puede aquí, sí, yo creo que yo también tengo this here. Sí.